Well, welcome everyone. I know it's hard to come out of the beautiful sunshine in Hawaii to come here and spend time out of your schedule to watch a talk about laser technology, which I find really exciting for MicroPulse. How many comprehensive ophthalmologists are out here? A few, good. And then retina surgeons are obviously the other half. So I'm going to approach this lecture talking to you about what MicroPulse can do for you as a comprehensive ophthalmologist, and then Sam's going to take over from the retina side too and talk to you about retina and how it's helped his practice. I do have a financial disclosure that Iridex has helped fund me to be able to come out here for this lecture, so thank them very much. So there's lasers that we have available from Iridex. We have different wavelengths, the 810 diode laser and also the 577 yellow and the 532 green. I currently have the 532 green. All these lasers have a MicroPulse ability. And then also later on, you can take a look, there's a newer pattern laser that's available too, that's available on the visible wavelengths for the 577 and the 532, which is the TechCell. And it's pretty neat technology that's out there too, so kind of looking forward to using that. The goals of the lecture, what we're going to do is to describe the MicroPulse technology and how we can use it for the anterior segment as well as the posterior segment, and the advantages as a comprehensive ophthalmologist of how I have incorporated this into my practice. With the IQ532, it gives us real fine control of the photothermal effects. So we get tissue-sparing technology with sublethal elevation in the tissue. So we don't see any destruction of the tissue that you would see with a traditional continuous wavelength laser. Now, with the IQ532 in the MicroPulse mode, we can use it for multiple things. We can treat the anterior segment, and we'll call that laser trabeculoplasty, or what I'll refer to as MLT. And also for treatment of the posterior segment, typically for the retina doing a grid therapy, whether you're doing it for diabetic macular edema, central serous retinopathy, branch retinal vein occlusions, central retinal vein occlusions, and even an example of radiation retinopathy. Now, what's the mechanism behind the MicroPulse? Well, we have to think of it as a kind of a continuous wavelength laser that's then chopped into short segments. Now, these short pulses will minimize the time in which that laser induces the heat or thermal reaction within the tissue. So we give a longer rest time to allow that tissue to cool back to its baseline temperature. So when we look at continuous wavelength and we look at MicroPulse, if we look at the slide above here, this is the continuous wave laser. We turn the laser on, and as that laser energy is being applied to the tissue, the thermal reaction takes place. So we can see a rise in the heat or the temperature within that tissue. And as soon as the laser is shut off, we see a cooling back down to baseline. So if we now take this continuous wave and section it into multiple pulses within the same time frame, we can see a rise within the tissue temperature. However, that rise is going to be less than what we would see with a continuous wave laser. Therefore, we're not building the heat up enough to create thermal damage to the tissue and not causing any visible reaction. When we look at continuous wave and look at MicroPulse, when we think of MicroPulse, we also have to talk about a few terms. And the two terms that we have is what we call the adjustable width, which is the on time, and the interval, which is the off time. So we have two ways we can affect how that heat's generated in the tissue. If we have a shorter width time, then we have basically less energy that's going to be applied, or if we take that longer interval between the pulses, we can also cool off the tissue that way. So with MLT, we have a 15% duty cycle, or basically the time that the laser's on is for 0.3 milliseconds and off for 1.7 milliseconds. When we do retinal grid therapy, it's on for a 5% duty cycle, so 0.1 milliseconds will be on and 1.9 milliseconds will be off. And I'll show you what I mean by that when we look at this next slide. When we have the continuous wave laser, we see that the pulse of the laser turns on and then continues for, say, a given segment, say 200 milliseconds. We can take that same laser and then section it into multiple pulses. And so as those multiple pulses are taking place, once again, that heat is not being generated high enough to create thermal damage. So we have the pulse on time, and that's the duration, and the pulse off time, which is the interval. So over that period of time, we can then section that laser up enough to create what we call the duty cycle. And so with the duty cycle, at a 5% duty cycle, it would be on, say, 0.1 milliseconds and off for 1.9. And this is an example of a 10% duty cycle where it's on for 0.2 milliseconds and off for 1.8. And just like if you went into a 15% duty cycle, it'd be on for 0.3 milliseconds and off for 1.7. Everyone kind of understand what we're talking about? Okay. So here's an example of the trabecular meshwork, and this is in a cadaver eye. And Knocker did this demonstration where you applied traditional ALT therapy, and what you can see is actual visible scars within the trabecular meshwork. So we have areas of treatment. This is done with a 50 micron spot size at 1,000 milliwatts of power and 100 milliseconds. So this would be kind of your traditional treatment that is taking place in the trabecular meshwork with continuous wavelength laser. If we look at the trabecular meshwork now, and we put these two side by side, we probably don't really see a whole lot of difference. But one eye was treated with MicroPulse, and the other eye was the control eye. And so you can see with the MicroPulse treated eye at 300 milliseconds and 300 micron spot size, and even with 1,000 milliwatts of power, there is really no visible reaction within the tissue as compared to that of the control eye. So we can feel very comfortable using these higher power settings in the MicroPulse mode, knowing that we're not causing any harm to that tissue. And that has some theoretical advantages in the future because it becomes more repeatable or able to repeat this treatment in the future, just like you would with, say, an SLT. So with laser trabeculoplasty, the laser energy is applied to the trabecular meshwork, and this will help increase the outflow facility. Our main indications would be that of patients with elevated IOP or pressure that's high enough that's still causing damage to that patient's optic nerve, so we want to bring that pressure down. And we find that it's very effective in controlling pressure in patients with primary open-angle glaucoma and patients with pigmentary and pseudoexfoliation glaucoma. When we compare ALT to SLT, we know the traditional argon laser trabeculoplasty, we used to think it kind of caused shrinkage of the trabecular meshwork and adjacent stretching, which kind of opened up that angle a little bit better. In reality, it may be more of a release of cytokines and macrophages that may also be working to lower the pressure. We typically can't repeat that ALT because it does create scar tissue within the angle structure, and the more you treat, the more scar tissue you're going to develop and actually a worsening of the pressure. With SLT, it does target the intracellular melanin and activates those macrophages to clear the pigment within the trabecular meshwork and allow the outflow facility to work better. It uses a larger spot size, approximately 400 microns in size. It's repeatable. However, the laser itself is fairly expensive to have and maintain. And it does have limited use in the fact that the SLT can only really be used for SLT. Now, you can get a combination laser where you can use it for YAG and SLT, but obviously the expense goes up for that. If we look at MLT, MLT is very similar to that of the SLT in the fact that we see no thermal damage to the tissue within the trabecular meshwork. And once again, that was demonstrated on the previous pathological slide in the specimen of the cadaver that showed there was no thermal uptake or no damage to that trabecular meshwork. It uses a smaller spot size than we see with that of the SLT, about 300 microns instead of 400. Theoretically, that might be a little easier maybe to get into the angle in some cases if you have slightly narrowed angle. It targets the intracellular melanin and activates the macrophages. We don't see any postoperative inflammation with this because we're not seeing that thermal reaction and liberation of a lot of pigment that could lead to inflammation. We do know it is repeatable, and it's a lot less expensive than what it costs to get into the SLT. And the other theoretical advantage is that it does give us multiple uses, meaning that we can use this laser for many things, whether it's in the continuous wave mode or in the micropulse mode. So it makes it a lot more user-friendly and cost-effective in today's world and economy that we're dealing with. So what I did first is looked at 13 eyes. I decided to do MLT, and these patients opted for treatment with MLT. And at that time, I was using 300 milliwatts of power. Now, all these were newly diagnosed open-angle glaucoma patients who elected to undergo the MLT. And the mean IOP was 26, and they had a range anywhere between 21 and 38 millimeters of mercury. Now, none of these patients have had previous treatment, and 5 had ALT actually done in the fellow eye. I was using the IQ532 laser, which is the green wavelength. Treatment was done for 360 degrees in continuous spots, so each spot was laid right next to each other in 360 degrees, so it's approximately 100 spots, roughly anywhere between 90 to 110 or so, depending on the size of their angle and how you put the spots in. Preoperatively, I did give bromidine 0.15% just from years of doing ALT and everything else. We still pre-treat to prevent any pressure spike. Whether or not I need it, I'm not sure, but I just did it for safety reasons. And also, I did give a drop of prednisolone 1% just one time, and that was at the time of treatment. We seem to see less photophobia post-operatively. Patients don't complain of as much irritation right immediately after the laser. So I do that with just one drop at the time of laser, and that's it, nothing post-operatively. And I was using a rich 4-mirror lens. So once again, these are the treatment parameters. If we look, this is kind of a picture of what the face of the computer would show. Up top will be our port, or basically how many micron spot size we're using. It was a 300 milliwatt power, 300 millisecond duration. And if we look here, this is our duty cycle. So this would be a 15% duty cycle, so it'd be a 0.3 milliseconds on, 1.7 milliseconds off. So at 4 months, what were our results? Well, at that time, of the 13 patients, pre-op IOP was 25.7, post-op IOP of 21.1. So we saw about an 18% reduction in the pressure. There was one patient, if you look at patient number 11, they did have a rise in pressure of about 1 point or 1 millimeter of mercury. So it had a 5% elevation in pressure, but otherwise most people did respond to the laser. This one patient then subsequently underwent a traditional ALT and had no response either. So whether I was using MicroPulse or a traditional ALT, at that time I saw no difference. So they're probably just going to be a laser non-responder. I then decided to look at 700 milliwatts and see what would happen with that with patients. So we had 14 eyes that were enrolled into this. They elected to undergo the MLT. The mean IOP was 23 millimeters of mercury with a range anywhere between 19 and 26 millimeters of mercury. None of these patients had had previous MLT before, but 6 eyes had previous ALT, and 2 of the eyes were currently on pressure-lowering medications on timolol. So with the increased power trial, once again, this is a screenshot. This is showing the 700 milliwatts of power and a 300 millisecond duration and a 300 micron spot size with a 15% duty cycle, and we treated 360 degrees. So at 1 month post-operatively, we looked at those patients, and if you see patient 3, 4, 7, 8, and 11, 12, those are all the patients that have had previous ALT, while patient 3 and 4 had previous ALT and were also on pressure-lowering medications. And we see that the preoperative IOP was 23 and the post-op IOP of 18.9, approximately a 17.8% reduction in pressure. But by 4 months, this actually got a little bit better. We saw preoperatively of 23, post-operative 18, or about 21.7% reduction in pressure. So we're seeing a little bit better effect at 4 months when we compare that to 1 month with 700 milliwatts of power. If you look at those eyes that had previous laser and those people that didn't have previous laser, I tried to look at that and see, was there a difference with those patients that were treated versus those people that weren't treated with laser. And at 1 month, we saw just maybe slightly better lowering in those patients who had no previous laser compared to that previous laser, but pretty much statistically a wash there. But at 4 months, I found something kind of interesting. With no previous laser-treated eye, we saw about a 21.2% reduction, and those patients that had previous laser actually responded slightly better. Why? I'm not 100% sure whether the trabecular meshwork was primed or pumped for future treatment, but we did see just slightly elevated percentage of pressure lowering in those patients who did have the previous laser, which is counterintuitive because their pressure was already down a little bit. You'd think it'd be hard to drive it even further down, but they did a little bit better. And lastly, we started to look at using 1,000 milliwatts and to see what kind of effect we would get with that, knowing that it was safe in the cadaver eye, that we did not see any breakdown of the trabecular meshwork with using these higher wattages. So 18 eyes elected to undergo the MLT with a mean IOP of 23.9 and a range between 19 and 39 millimeters of mercury. And any patient was able to get into this trial whether they've had previous ALT, whether they've had a previous MLT, or were currently on medications. So in this group, once again, looking at the screen settings, we had 1,000 milliwatts of power, 300 millisecond duration, 300 micron spot size, and a 15% duty cycle, treating the 360 degrees of the angle. And at 1 month, looking at the numbers, we had a pre-op IOP of that 23.9, which was then reduced down to 18.7, or approximately a 21.8% reduction in pressure with this. If we also look at the patient 7 and 8, this was a patient who had previous MLT at 700 milliwatts and had a pressure initially of 25, which was then reduced to 22. But then using the higher setting, we're able to drive that pressure down to 17. So we thought that was pretty significant in the fact that we could actually get more effect going from a 700 milliwatt power to 1,000. And whether that's because they've had previous treatment, they respond a little bit better with the next treatment, or maybe if I started off with 1,000 initially, would I have been able to drive that pressure from 25 to 17 with just one treatment? I don't know, but we did see a nice effect even with people who've had previous treatment with MLT. So now the question is, what power setting should we use? Should we use a 300, 700, or 1,000? When I gave this kind of talk over at the academy, at that time I didn't really know my results for 1,000 at that point, but I did know that we were seeing a nice effect with 700, so at that point I was suggesting 700 milliwatts to start off with. Now that I'm looking at the results, I'm kind of pushing my way to using 1,000 in everyone. I'd really like to see what the 4 months results will be. Based on this trend, we can already see that people do better with a little bit more power, and it's 18% at 4 months with 300, which is comparable to the 1 month at 700. However, as you see, as we go up to 4 months at 700, we're seeing a 21.7% reduction, which is very comparable to the 1 month at 1,000. So if we follow the trend line, we're hoping to see maybe a 23, 24% reduction at 4 months with 1,000 milliwatts, but that data is yet to come. Other questions we have is, what's the long-term effect of this? Well, we know with ALT, we see about an 80% effect at 2 years and about a 50% at 5 years. So those patients, the problem with them is that we've treated them and we've created scarring, and we have nothing else that we can do except for going on to additional medications or an SLT. But now we have the ability to use MLT to treat those patients because we do know that they still will receive some effect even with previous ALT. With MLT, it's still unknown. We do know that we have a nice effect by 4 months post-treatment, and we do know that it is repeatable. And so hopefully with MLT, we'll see a long-lasting effect too over time. So what about MLT as an option? Well, the advantages of the MLT are this. Those patients who have lost effect over time, whether they're on medications or had previous ALT or laser therapy, those people can respond to this. Patients who had inadequate response before from a previous laser may respond to MLT better. Those people who have had previous ALT procedures that you can't repeat, those are perfect candidates for this procedure too. And it also benefits the patient as well as the doctor. If you think about a lot of these patients who are kind of elderly or getting older, we know the effects of dry eye definitely increases on them. And when you start adding a preservative into a lot of these topical medications, and especially if you're using like an aqueous suppressor, like a beta blocker, that's going to cause more keratopathy too. So if we can try to avoid medications in these people, the better off they're going to be, the better visual quality they're going to have too, and the quality of life of not having to remember to put drops in their eyes all the time. I mean, the women sometimes like the certain medications like, Lumigan and stuff because their lashes will grow, but the men kind of hate that when their lashes are so long. So, if you can try to avoid that in males, that's great. And so we can maybe use this technology in place of a drop to give them just better quality of life. And the biggest thing I think too is just the compliance issue. You're never quite sure is that patient using their drops. And everyone I'm sure has this where the patient will walk in, their pressure was 18, they come into your office, now the pressure's 21 or 22, and you're thinking, oh gee, I gotta add another drop or I may have to do a laser. And you talk to the patient and you say, your pressure's up again. Oh yeah, doc, I forgot to use my drop last night. Well, did you forget to use it last night or did you forget to use it multiple nights maybe in the past? And so from that standpoint, you always wonder about compliance in these people. So what's the procedure code we use? We use the procedure code 65855, which is trabeculoplasty by laser. The CPT code doesn't state which laser technique is being used, whether it's an ALT, an SLT, or an MLT. What I'd like to do now is kind of switch gears and move on to the posterior segment, and this is going to be kind of as a comprehensive ophthalmologist, what could you do with this laser in the posterior segment? I'll discuss the MicroPulse for the treatment of retinal diseases, and I'll give kind of 8 cases about how MicroPulse has helped me and helped my patients in my practice. So in the posterior segment, we think of the continuous wave length again. We can use that continuous wave to treat traditionally for, say, macular edema, such as traditional focal grid therapy. We can use the continuous wave for proliferative retinopathy, whether you're doing PRP for proliferative diabetic retinopathy or neovascular glaucoma. Patients who have retinal tears, this laser works great at treating those retinal tears. Not as much anymore for choroidal neovascularization. Maybe if it's an extrafoveal or even a juxtafoveal in a patient who maybe has 5 heart stents and has been having multiple TIAs, you don't want to use Avastin or Lucentis or any of the anti-VEGFs. You can consider using a continuous wavelength laser to try to destroy the membrane or neovascular complex. But I'm going to kind of focus now on the MicroPulse mode, and we can use that mostly for in the grid pattern to treat macular edema, whether it's from diabetes, branch retinal vein, central retinal vein occlusions. I'll even show an example of radiation retinopathy. So with the MicroPulse mode, the way I currently set it up is that I'll do a test spot in the continuous wave mode. So I start off in the continuous wave mode, typically 100 micron spot size, 100 milliseconds, and 100 milliwatts of power. I'll then titrate that up until I see a white burn, so I know I've had a tissue reaction. I'll then flip the machine over into the MicroPulse mode and set it at a 5% duty cycle. And this is extremely important to remember, 5% duty cycle when you're dealing with the posterior pole and within the central vascular arcades or zone 1. And Sam will kind of explain that a little bit more to you, but it's a 5% duty cycle. Please do not go to a 10 or 15% duty cycle. You may get a thermal reaction that you don't want, and it becomes not foveal friendly. So make sure you use it in a 5% duty cycle. And I'll maintain the spot size, but now what I'll do is I'll double that exposure time and double the power. So this would be an example of what maybe a laser technique would do for you, or how you would do it. This is putting on a standard, probably standard Mansour lens, 1.05 magnification. You can see the patient's had some previous focal treatment done in the past. And what we're doing is we're basically doing kind of a paintbrush technique right across the central area of edema. And I go in a back and forth manner, and then I go up and down, because what we want to do is to get a high density, low intensity treatment over that area. And so by doing this, you can go right through the fovea. It's foveal friendly. It sounds very strange to do. In fact, the first time I did it, I was freaking out. I didn't know what to do. Am I supposed to do this, not do this? Well, what I did is my initial treatments, I avoided the fovea. And so what I would do is then shoot a fluorescein afterwards and make sure that there truly was no uptake. And afterwards, you felt very confident, very comfortable doing this, because at a 5% duty cycle, you will not generate enough heat or energy to create a thermal burn or a thermal reaction in the back that becomes lethal. So you can feel very comfortable treating right over the fovea, and you want to apply a very high density pattern. So here's a couple of case studies. We'll run through 8 of them real quickly. And this is all with the 532 or the green wavelength MicroPulse mode. The first case was a case of a type 1 diabetic who had a previous focal grid back in February of 06 and in July of 08. Visual acuity was 20/20, and we can see some areas of edema right in the subfoveal, juxtafoveal region. MicroPulse treatment was carried out in December of 2011. At that time, I was only using 70% of my power for the test spot, and you can see a huge advantage and a huge excellent result with this, which is, I'm kidding, you didn't see much at all. In fact, visual acuity is still 20/20 and really no change on the OCT. So at that time, the patient came back, and this is now in March of 2012. At that time, I knew that you had to use a higher power setting. So at that point, we were using the 100 microns with the 200 millisecond and 200 milliwatts of power and 5% duty cycle. And now we can see a nice resolution of the central edema at that higher setting. This is a month post-laser. So if we line those people, or the OCT up, this is the initial treatment right here, following with a presentation, and then this is after the higher settings of doubling the power and also doubling the duration, and they did real well. Next case was a type 2 diabetic who had a previous focal grid back in February of 08, had some steroid injections in July of '08 and also November of '08, and also another grid therapy with continuous wave laser and another steroid injection of February of '09, visual acuity of 20/50 with a large macular cyst. So this patient then ended up having a MicroPulse treatment done in December of 2011. Once again, I was using a 70% power at that time. However, this was interesting. It did respond. Even at the 70% power, we can see nice resolution of the central edema, and visual acuity improved from 20/50 to 20/30. I don't recommend treating at 70% power. I still recommend now the higher settings, but even at that setting, we were able to see some effect with the MicroPulse laser. Next case was a case of a type 2 diabetic who ended up with a Lucentis injection, a Vacid injection, and said they do not want any more injections. And so this is how they presented. They presented with 20/40 vision with some large area of central edema, a lot of diffuse edema throughout the retina. So the patient underwent MicroPulse treatment. They had 536 shots put in, 100 microns, and 200 milliseconds, 300 milliwatts of power, 5% duty cycle. And it's not perfect, but we're seeing a nice starting of a resolution of some of the edema that they had centrally. The patient did describe the fact that they had less metamorphopsia after the treatment, and they felt that their overall visual acuity was improving, and they did improve from 20/40 to 20/30 with just one session of MicroPulse treatment. Next case is that of a branch retinal vein occlusion who presented in November of 2011. They've had a previous grid treatment in September of '07, had some steroid injections along with another grid treatment. And this is how they presented on OCT with areas of edema. They would have this kind of remittent bouts of edema. You'd treat them, they get better. You'd treat them, they get better. You'd treat them, they get better. So now they present in November of 2011. Used 268 spots, 100 microns, 200 milliseconds, and this again was at the 70% power because this was early on in getting the laser. And we really didn't see a whole lot take place. Visual acuity actually worsened by a line from 20/50 to 20/60, and the central edema was still present and not really much better after the initial treatment. However, when they returned in March of 2012, I knew better to use a little bit higher power setting. This time we used 100 microns, 200 milliseconds, 200 milliwatts of power, and we can see some nice resolution of the edema with the MicroPulse treatment, and the visual acuity improved from 20/60 to 20/25 after treatment. And then this is many months out also. It's showing the long-lasting effect of the treatment from November, and this is almost a year later after MicroPulse, and it's still holding well today. So when we look at that case, once again, this is showing earlier treatment with only about 70% power, and then now doubling the power, doubling the duration, and seeing a better effect with the MicroPulse at those settings, going from a vision of 20/50 to 20/25. Next case is a branch retinal vein occlusion. This patient had no prior treatment, said that their vision was down for about 2 to 3 months, and we can see this large area of edema. This is not going to be your classic case of MicroPulse, but I'll show you what happens. Patient came back to get the treatment done. They couldn't get it done that day, so in February 22nd, 2012, they ended up having 377 shots, 100 microns, 200 milliseconds, 400 milliwatts of power, and a 5% duty cycle. And we can see some nice resolution of the edema, but what's more important to see is the fact that this was February 22nd, and this is a week later with treatment. And I just thought that was amazing. And I would never bring the patient back to do an OCT in a week, but what happened is this patient actually came to the front desk for another reason, was saying that their vision was so much better. And I sat down and I said, maybe it's just psychological. I had laser done, I'm going to see better, that type of thing. And so I said, well, why don't you come on back and I'll put you on the OCT. So I put her on the OCT and we saw this, and I just said, wow. I mean, this is kind of like one of those wow factors, like doing LASIK, you get a wow factor. The only downside, though, is I think she's doing so well she never followed up again. So I don't have any long-term results of this patient. But she must be doing okay because she's obviously not back in my office. And this is just showing the power of what sometimes you can get with MicroPulse treatment. And our next case is that of a patient who had previous PRP for neovascular glaucoma, had some chronic macular edema, and was complaining of some metamorphopsia. They declined any steroid or anti-VEGF treatment and had visual acuity of count fingers at 6 feet. Now, classically, we don't treat central retinal vein occlusions for macular edema. We just know it doesn't work with continuous wavelength mode. We don't do that, but she was, insistent that her vision wasn't as good, but she just did not want anything done. I did mention, well, we have MicroPulse, and we can try it on you and see if we can get any effect. And in this situation, we did the MicroPulse at the higher settings, and the vision did improve from count fingers at 6 feet to 2400, which I thought was pretty good because she had an ischemic CRVO, obviously, and had a lot of damage to the photoreceptors and everything else. But she said she saw better. Her improvement of her metamorphopsia was better. And overall, going from count fingers at 6 feet to 2400 is almost twice as good a vision at that level. Next case was that of a case of radiation retinopathy, and as you know, with radiation retinopathy, typically what we were seeing is if you did a fluorescein on this patient, you would see the foveolae vascular zone was actually getting larger and bigger, and the last thing you want to do is to apply continuous wavelength laser in an area that's already ischemic from radiation treatment that was done in the past. So in this person, you would never think about using continuous wavelength laser. However, I discussed with this patient the ability to use MicroPulse. This happens to be my golf partner. And so obviously with my golf partner, I want him to see well, and he wants to see well. And so I talked to him about the potential of using MicroPulse to help with some of his metamorphopsia that he was developing. And so he came back and had treatment carried out on his eye on May 30th of 2012. 278 shots were given, 100 micron spot size, 200 milliseconds for 200 milliwatts, and a 5% Dewey cycle. And we can see just with the one treatment that we're seeing some resolution of his central edema, and visual acuity improved from 2100 to 2080, and we can see a nice less thickening on the OCT too. He's down in Florida right now playing golf too, so I have no idea how he's doing, but I think he's doing pretty good. And this is our last case, and it's a case of a type 2 diabetic who presented with some clinically significant macular edema. He had previous focal grid carried out in May of 2010. Their visual acuity is 20/25 on presentation. We can see our area of edema just outside the subfoveal region. So in this case, we used a MicroPulse treatment. It was carried out in April of 2012, 325 shots of 100 microns, 200 milliseconds, and 200 milliwatts of power at a 5% Dewey cycle. This was the pre-op OCT. And when we see the patient back in June, what we're seeing is actually a worsening of the edema. So before, where they had some edema outside the central foveal region, but it was clinically significant because it was greater than a disc diameter in size within a disc diameter of the center of the fovea. We now are actually seeing some cyst formation and some edema encroaching within inside the central foveal region, and a thickening of the retina, and visual acuity, though, staying about the same. So what should we do now in this patient? Do we sit back and consider maybe a steroid injection? Do we consider anti-VEGF therapy? Do we do more laser, whether we go back to a traditional continuous wavelength laser, or do we add some more MicroPulse? Or another option, of course, as anything, is to do nothing. So patient returns in September of 2012. Remember, the initial MicroPulse was carried out in April of 2012. And when we see him back in September, we're seeing a little bit resolution of the edema that was present on our last exam. And when we look at the OCT, we can see more resolution on that of the edema. And no treatment was done. So in June, I didn't do anything. I elected to do nothing. And we still saw some improvement of the macular edema. So in September, though, we still had just some edema there. Do we now consider treatment? Do we try steroids? Do we try anti-VEGF? Do we do more laser at this point? Once again, patient returns in December, and I decided not to do any treatment because we were starting to see some resolution of the edema, and we wanted to see if maybe the initial effects of the MicroPulse was able to work. So when the patient returned in December, we can see more resolution of the edema. Visual acuity is now improved from 20/30 to 20/25 plus 2. And when you look at the OCT, you'll see nice resolution of most of the edema that was there or present from the previous exam. So when we look at that over time, we have to remember that sometimes with MicroPulse, we'll see this kind of a delayed response to the MicroPulse treatment after initial worsening of edema. I've seen this on several patients. It's not a lot of patients, but I have seen it on a few patients. So I feel a little bit comfortable in sometimes doing watchful waiting. And it's hard as a physician to sit back and do nothing, because doing nothing is really sometimes doing something. And so you kind of got to remember that in some cases when you apply treatment, that treatment takes some time to work. And so don't worry sometimes about jumping in trying to do something differently. Let the effects of the initial laser work for you, and you'll see that over time you'll see some nice effects with the initial treatment that you did. My general rule now is at least definitely wait 3 to 4 months before I would retreat. And sometimes, like I said, if I'm seeing improvements still on the OCT, I'll go further out. I'll go 6 months or so before adding any additional treatment. So in conclusion, we talked a little bit about MicroPulse technology and how we can use it as a comprehensive ophthalmologist from the anterior segment to the posterior segment. We also talked about how the IQ532 has great versatility. We can use it for continuous wavelength treatment, whether you're doing an ALT or peripheral iridotomy. You can do focal grid with it, PRPs, retinal tears, choroidal neovascularization, and how the benefit of the MicroPulse technology can be used for treatment of trabecular meshwork for those patients with glaucoma. As an MLT, you can use it for grid therapy for patients with macular edema. And the future ability of this laser, we don't know yet. There's still some things that are in the works right now with using MicroPulse. And so hopefully we'll be able to see even future technology being available with this type of laser. I do want to do a special thank you to 2 of my residents who assisted in this presentation. They got a lot of the data together for me. They did actually a lot of the treatment too. So Dr. Warner and Dr. Benjamin, I want to thank them. And otherwise, I want to thank you guys for being here, listening to me talk when it's beautiful out there. And if you're a Michigan State fan, you know what this means. It's my little Spartan S sitting on the back deck. My wife gave this to me, who, of course, is also an ophthalmologist, but is sitting by the pool, so she knows how important this lecture was. Well, thanks again.
Well, it's amazing. We still have some retention of the quorum. I'm impressed, especially at Hawaii. Especially they give us afternoon sessions, too. I'm going to be following David's excellent presentation. He discussed, of course, both the anterior and posterior. My name is Sam Mansour. I'm a vitreoretinal surgeon, and what I'll be discussing here is pure retina applications. This is the traditional disclaimer. Please, I'm going to discuss not only the use of laser, but some drugs that I don't recommend you try it at home, and if you do, we never met. The financial disclosures, I am a consultant for Iridex. So the outline of the presentation is going to be in 2 major sections. What are the clinical uses of MPLT, MicroPulse Laser Therapy, and also how is it integrated into the current clinical practice? And that's the part where, you know, in 2 years of presenting this, that's where we allow a lot of interaction and discussion about specifics of treatment. So one of the best summaries that I found was from our good old father, Hippocrates, about first doing no harm. And this really is very relevant to the use of MicroPulse in the sense that, I don't know about you, I don't know how many retinal specialists are in the audience, but when I finished my fellowship in '92, I was not a big fan of doing lasers. And it was kind of a weird confession for a retinal surgeon who lives and makes a living by laser. But it was always, to me, in the back of mind, like a Civil War surgeon where you had to amputate the leg to save the life of the person. But it's not like you go, wow, that was great, I fried that person's retina to save it. So since the beginning, I was always looking at doing subthreshold type treatments particularly for diabetic macular edema. We're all familiar with what conventional continuous wave laser has as far as complications. There's anterior segment complications like corneal, iridoid, and lenticular burns, choroidal neovascularization, particularly when you cause a break in Brooks membrane using short duration, very intense small spots. Even though the incidence is very low, when it does happen, we know it's devastating. Foveal photocoagulation, especially those of you that have been in teaching centers know that's not that infrequent. Foveal shutdown, especially in cases of severe macular ischemia. Also, epiretinal membrane formation, choroidal hemorrhages, RPE atrophy with scar expansion, particularly with heavy confluent burns. And as was addressed, you never know You know, I always am very cautious about judging the overtreatment of a previous ophthalmologist because you weren't there at the session. And as one of the members of the audience mentioned with PDT, we didn't know until you now see these patients later on the dramatic scar expansion that has happened. Avascular submacular fibrosis also we can see, especially in patients who have a lot of hard exudates. Anybody recognize this slide? Some of you do. This is one of the standard slides from the ETDRS. Here is a pre-treatment. This was sent us as this is what you should aim for. Here is a pre-treatment slide of the left eye of a diabetic with a cercinet ring of hard exudates. And you can see it going right through the fovea and a cluster of microaneurysms. And here is, by the book, application of focal laser photocoagulation. Now, granted, some of us are not, most of us hopefully would not be doing this type of intense treatment, but that was accepted then. And here's 1 year afterwards. Vision is very close to 20/25 plus, which is great, right? But what do you have here? Okay, it's one of the Hawaiian Islands, right? And the patient never fails to describe to you in detail every time they see you, yes, doctor, I can see this, but there's this waviness, there's this area I don't see well, right? So this is kind of the impetus that I think influenced a lot of us say, we've got to do something better. Well, if you remember, the ETDRS folks did the modified ETDRS protocol, remember, where they reduced the intensity of the spots and the parameters. And the goal was you would see it on fluorescein angiography, but you wouldn't see it clinically. But guess what? Those patients also had subsequent scar expansion, and they became symptomatic in describing the metamorphopsia. Here is a slide of a patient. This is about 5 years ago. This is before I had access to MicroPulse or any, and this is, if you look at the settings up top, this is using the Iridex 532 at the lowest possible settings, 50 milliwatts, 30 milliseconds. They don't go lower than that. And it's a 200 micron spot size, so very large. So I figured, hey, great, this is probably going to be safe to try to treat this patient. And if you can see, this is after treatment. This is about 2 months after treatment. You can still see small areas of spots of hyperpigmentation where the treatment. And on fluorescein angiography, you can see these spots. Now, I didn't go through the fovea. I came pretty close to it. But again, this patient, very diligent, he describes to me, he said, Doc, I can see clear, but you know what? I see the waviness. And they described that metamorphopsia. So this is one of the reason I include the slide for this talk is a lot of people have approached me, including retinal specialists that you've heard speak at the podium too, say, well, look, I can get that same effect with subthreshold. And I was going to put a slide of Clint Eastwood. I said, go ahead, make my day. Try to do that through the fovea. That's the real test. Okay, so if anybody is saying, well, listen, you can try to do that and jury rig it and try to go through the fovea, good luck. I wouldn't recommend it. So in summary is, if we know that this area, if on a continuous wave laser treatment, this is the area of total destruction, but this penumbra of indirectly treated tissue is what is thought to be mediating the effect of MPLT. If we can achieve that on this side with the entire spot, rather than having to depend on kind of a volcanic core and then reap the benefits of the surrounding tissue, then this would be great. Furthermore, we can actually treat more surface area, okay, rather than having to keep the healthy distance between spots. You can actually do an entirely confluent treatment, knowing that it will have a great effect without sustaining the pigmentary alterations and tissue damage. And one thing some of you may not know is, you see, there's the 577 laser, which is the one I use, and on top of the laser is the TechCell. That TechCell that David described is the new pattern delivery system. I would strongly encourage you to go and play with this, and if you don't have time now, but also later in the meeting, because now they can deliver a customized, very detailed customized pattern. And it's very impressive and will make this already quick laser treatment even quicker, but more importantly, more consistent. So how does it work? This is a bit of a review of what we've traditionally known about grid laser photocoagulation, not focal, but grid in the treatment, particularly of macular edema. One is that there's a destruction of the outer retinal layers and RPE, thereby permitting better diffusion of oxygen from the choriocapillaris into the inner retinal layers. Another is debridement of sick or fatigued RPE cells, and that results in enhancement of the outer blood retinal barrier, which in turn favors the movement of fluid from the retina into the choroid. Another effect is reducing the total surface area of abnormal vessels, okay, thereby reducing the amount of leakage. We know this is a minor effect because everyone in this room knows when you're firing that laser spot, you're not affecting the vessels or inner retinal vasculature anywhere near as much as the RPE and cells in the choroid. The last effect is the exciting effect, and that's almost, that whole thing is a topic for another hour lecture if we want, but stimulation of the RPE to release biochemical mediators to antagonize not only VEGF, but other mediators that promote macular edema and neovascularization, as well as other beneficial factors. So if you look at the evolution of MicroPulse therapy, if you look at this chart, the ETDRS, using the ETDRS parameters, both ophthalmoscopically on fluorescein angiography and on fundus autofluorescence, there was visible damage. There was visible tissue alteration. Even when you go to barely visible, kind of the modified ETDRS protocol, you still had visibility both ophthalmoscopically and on these imaging studies. As you keep progressing, okay, you start getting into the micropulse region. Now, with micropulse, if you crank it up to greater than 50% duty cycle, what you do is, yes, you're able to reduce some of the manifestations clinically. However, you do see them on fluorescein angiography and autofluorescence. Once you start getting into this range is when it becomes more palatable, if you will, in terms of tissue preservation. So as David echoed, and we cannot overemphasize, once you start getting into the macula, or zone 1, and I'll tell you what that zone 1 is, it's not the same zone 1 as in ROP, then you do, that's the safest node. So I would highly recommend do not ever exceed 5%. Okay? And the other users of MicroPulse will tell you the same. So detectable retinal damage correlates with lesion intensity, and it can be reduced by using lower duty cycles on MicroPulse. So one of the interesting things that MicroPulse does, which hasn't got a lot of airplay, unfortunately a lot of this technique hasn't got a lot of airplay, as some of you know, is Vijosevic published in Retina in 2010 an interesting comparison of using a modified ETDRS protocol, right, applied laser that way, you can still see them here, and a subthreshold micropulse. So 1 year from that treatment, he did microperimetry. Okay, it's a very sensitive assessment of the central sensitivity of the retina. In the modified ETDRS, surprise, surprise, the sensitivity went down. In the MicroPulse laser treatment, you think, well, maybe it would be good if it went down, but not as much. No, it actually increased. And that's something you don't see with pharmacotherapy readily. So what are the clinical uses of MPLT? First and foremost, of course, in diabetic retinopathy. As I mentioned to you, I use the 577. There's no real great difference between the 577 and 532. There are some theoretical advantages, and that's why a lot of the retina practices will use the 577. But if you're in a multi-specialty clinic or a comprehensive ophthalmologist, the 532 probably would be your baby. We've used it in both focal, grid, combined focal and grid, as well as in scatter PRP, especially for PDR. I can tell you honestly right now that by far grid application is what I use 90% of the time in the clinical use. This picture illustrates one of the very first patients I had in June of 2011 when Iridex first dropped the laser at our office, and I was kind of said, okay, I'll give it a try and all this stuff, and voodoo medicine and all this stuff, and was interested because here's the patient, just type 2 diabetic, 20/30 -1 was the vision, no previous treatment. This is a patient who we tried who was a virgin, no previous laser, no pharmacotherapy, not even topical. So 52 days later, the vision's improved to 20/20 -2, and I didn't see anything. And this was an interesting thing because when the first feedback I got on these where the texts were coming and said, oh yeah, Mrs. So-and-so, she says that her vision really dramatically changed since she got MicroPulse. And I said, yeah, you know, that probably is a placebo effect and what have you. But sure enough, as we did the visual acuities, they improved. What's interesting, this is another patient. Again, patient had a previous Avastin injections type 2. This is after the third injection, 1 month after the third injection, 20/40 -2, there's still some leakage. And the question was, okay, do you come and do number 4? The vision really hasn't changed in that time. 2 months later, after a single MPLT session, okay, with the 577, there's still some leakage, but the vision has improved to 20/25. In addition, the same patient, the OCT, you had a little bit of microcysts, some small cysts in the juxtafoveal region as well, subretinal fluid here, gone, 61 days, one shot with my MPLT. This is the kind of cases that started making a believer out of me and saying, well, why the heck didn't we know about this sooner, and why didn't you just get out and storm the podium at the ACERS meetings and tell them this works. Here's another interesting case. Okay, this one with a lot of hard exudates. Massive edema on one side, not too bad here, but you can see the accumulation of hard exudates. Vision is 20/80. Single session. This patient has had, sorry, let me go back here. Had previous Avastin, 6 Avastin injections. So we're coming down now, and not a candidate for Kenalog or Iridex because of glaucoma issues. Now, what's interesting is, sure, there's been a reduction, a little bit of reduction in the central subfield mean thickness, and the vision has improved to 20/60, which is not bad. The interesting thing is, you look over that same time period, the hard exudates have started to minimize. There's been no change systemically, and the patient didn't stand anti-hyperlipidemic agents or anything. But that was one of the things that was interesting. It didn't make them completely disappear, but in 41 days to go from that picture to that picture was significant. And just to remember, these are applied as a very confluent grid, almost from arcade to arcade. The other thing I can show you also, illustrate on this slide. Here's another case. Again, bad type 2 diabetic, large cystic component. Vision is 2100. Had multiple Avastin injections, at least 6, and offered and accepted a single session of MPLT. And in about 2.5 months, vision improved to 20/60. Now, this is not a sexy slide. David showed you some sexy slides, but this is a typical severe DME case. And one of the interesting things that we've observed, not only myself, but other people who use the MicroPulse, is that if you have used triamcinolone, you know you can get some pretty nice, sexy reductions in the thickness, but the vision doesn't follow as well. There's often not as a correlated improvement in vision as there is to the reduction in CMT. That's not the case with MicroPulse. What we've noticed more often than not, that the visual acuity improves out of sync with the reduction in the OCT thickness. And we don't know why. We've talked at conferences that maybe you're improving the outer retinal layer functions by what you're doing to the RPE, but it is a noticeable effect. And here's an interesting hard luck case where not only have they tried Avastin, was given a single intravitreal triamcinolone injection, and here is the picture at the top, 3 months after that injection with recurrence of the edema. Didn't want to go any more with any shots. Given a single MPLT session. Now, it took a while. It's almost 6 months. No other intervening treatment since that time. There was no Avastin or anything afterwards, but 20/30. And one of the things I noticed with this case, and David alluded to in his talk, was our tendency, especially in retina, okay, it hasn't gotten better in 30 days, I'm going to try something else. I don't have, we want to go push. And this patient, fortunately, didn't show up in our doors because probably we would have tried something or may have been inclined to try something. But it was very humbling because 20/30 was nothing to sneeze at. I mean, it was very, very impressive how the vision had improved without us doing anything. So it has caused me to pause, and as David mentioned, sometimes doing nothing is really doing something, and it's true with this laser. This is the proliferative diabetic retinopathy 3-zone protocol that we are getting approved for at GW on our IRB. It's basically doing a 1-session treatment for a patient who has proliferative diabetic retinopathy. Zone 1 is defined as the area, if you take the center of the fovea to the equator and divide in half, that is the ring that outlines zone 1. Zone 2 is from that to the equator, and zone 3 is anterior to the equator. It's very easy and visible landmarks so you can discern. And the parameters, the entire retina is treated using MicroPulse therapy in a very confluent pattern. The only difference being, of course, is going from zone 1, where it's a 5% duty cycle, it goes all the way up to 15% by the time you get to zone 3. The power range increases also, as well as the spot size. But it is a confluent pattern. As David alluded to, we go right through the fovea. in all zones, but zone 1 is when we do that very, very tight confluent pattern application. And after a year and a half of doing this, there's been absolutely no visible pigmentary changes seen with this. So that was diabetic retinopathy. Retinovascular disease, David already showed you a good, case which, like we said, your mileage will definitely vary. You're not going to see a week gone like that, but we use it as both a grid, scatter PRP, again in micropulse mode, and also sector in retinal photocoagulation in branch retinal vein occlusion, again, also in micropulse mode. For JXT, we've used it as both combined focal and grid. Our initial pattern typically for JXT is a tight grid confluent over the entire lesion, and then if there's still recurrence, we may crank it up and do focal to the very dilated sections of the vasculature. What do we know has been published so far, particularly with regard to branch retinal vein occlusion? Parati especially has published in both the British Journal of Ophthalmology in 2008 and Ophthalmology in 2006. Again, this is using the 810, that MPLT is at least as effective as continuous wave laser. It acts more slowly. The use of Kenalog 2 weeks before MPLT has shown to cause a more rapid resolution of the ME, as well as achieving a longer lasting effect. We don't know about the effect of anti-VEGF agents. In JXT, as I told you, we also have used it, but we don't have any large studies to report on at this point. CSR. CSR probably, as you know, it's a very easy one to show an effect. You can almost sneeze on the patient in some cases and the CSR may go away. However, it's the toughies, the ones that keep leaking for a longer time or recurrent. Now what do you do? How many of you have done PDT for recurrent CSR? PDT, 2, okay. I personally have not done it in quite some time. I know one of the other retina specialists in the university, Javon Mathura, he was a big fan of doing PDT for recurrent or tough cases of CSR. What's been published has been pretty impressive. We knew that subthreshold laser was good at stopping CSR in some cases. However, once it comes close to the fovea, then even us who are fairly gun shy, you would not attempt traditional subthreshold laser to those. However, when you use MPLT, it gets you a very dramatic effect and fairly rapid and durable effect. And these studies have substantiated that, particularly due to the longevity. There is no clinically discernible evidence of laser-induced iatrogenic damage on even OCT scans. Okay, on the spectral domain OCT scans, they could not see any effect. That leak was sealed and tightly sealed for a significant amount of time. The fact that superior to Avastin is not really new news. We know that Avastin and anti-VEGF agents are not that effective for CSR. Here's the case of Andre Mia of CSR. Day 0, vision is 20/80. You can see that nice focal leak in the just in the juxtafoveal region. Here is day 14, 2020. Okay, that's kind of typical of what you would see with that. And a lot of the retinal surgeons are actually doing that initially. So they're not even waiting for it to resolve on its own. They're saying, what harm do I have? I think if you think about it, the one thing that has prevented us from treating these CSR patients right from the beginning is sure, they'll clear up on their own, but they come back 2-3 weeks, a month later, and they're the typical young, healthy, driven male that we see. They want to get their vision back quicker. But we've been always hesitant to try to use even subthreshold laser because of the potential complication of scar expansion, particularly. Now that's not an issue. So I haven't quite jumped to that level yet, but Javon Mathura, the guy who I told you who likes to use PDT for these recurrent cases, this is the primary therapy. How about ARMD? You say ARMD. And all this time we're hearing from the pharmas, they said, oh yeah, Avastin, Eylea, and so forth. There is a IRB-approved trial that we have gotten through a GW, which looks at, it kind of revisits the CAP trial. Okay, the high-risk drusen patients, these kind of patients. We remember from 20 years ago, we know that you can make drusen disappear very nicely with laser. That's a fact. We know that. The problem is, okay, at what price? There are potential complications because we know that these types of patients, their RPE Brooks barrier is not normal. So you have to be really careful. And some of you remember the parameters that were used in the CAP trial were like the modified ETDRS. So it's not surprising that complications did develop and that the visual acuity improvement was not commensurate with the disappearance of the drusen. However, we're now revisiting this because if we can make not just the drusen disappear, but if you're altering the RPE ultrastructurally down the road to be better at doing its normal activities, there is a potential that you may actually start to slow down the progression of dry or this high risk, to reverse the high risk. So that trial is just started as of last month. So hopefully later this year we'll be able to report some interim data on that. But it's exciting. And it is a confluent, unlike the donut application that was in the original CAP trial, this is going to be a very confluent treatment. Yes? Go ahead.
Last picture you showed.
Mm-hmm.
Now, is that Mike Pascal for this?
Excellent question. Yeah, yes, yes. Not to this degree. I mean, that's a very dense grid, but the grid is, I think, is the largest that Iridex offers at the present is a 7 by 7. And one of the things, and we'll talk this after because practically, remember, you're not seeing a burn. Because you and I are used to the traditional kind where I see, okay, I buzzed here, and I keep just going. You don't see that. So how do you know that you're not over-treating or overlapping? So one of the nice things with the pattern delivery is allows you to, literally, it just projects that grid, as you know, just like, and you see it going like the Singer sewing machine, boom, 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 like that. So you can see where you've treated. The other nice thing is, so what if you overlap? Both David and I and all the users, we overlap. We know when we do those tight confluences, but we don't see we don't see sequelae out of that. We don't see the pigmentary alterations or overtreatment.
Did you just misspeak when you said you don't want to overtreat when you just said that you can't?
That's a good. Well, you can theoretically, but we just don't. The fact that we overlap in our treatments has not resulted in any visible tissue alterations at all. Then that's quite, I started out keeping a healthy distance like I did in my ETDRS training days. And then other users said, no, you don't worry, just go confluent. Jeff Luttrell, who's used it since the early 90s, said, no, don't worry about that. But he said, well, that's easy for you to say because you've got an 810 laser. It's different when you have a visible, so I was very, very conservative, but now I can just relay to you about a year and a half worth of data that has shown that there's been no visible pigmentary alteration. Retinopathy. There was a question during the break about, okay, well, we already use the continuous wave and it does a good job of welding the retina, so what's the big deal? Use the MPT. In some of the cases where you have, and this is a good illustration, where you have lattice. A lot of you know that with lattice, we have to be careful as to how close we get, and we know the retina is very thin before it even reaches the actual lattice patch, the visible lattice patch. The nice thing with using a very large spot size and confluent treatment in a 15% duty cycle. So you will see visible tissue alteration, but not the white-gray burns that we see. It allows you to treat right up and surround it very nicely with multiple rolls, and it almost looks like cryo, okay, but very light cryo, but with the confluency of cryo, okay. So again, too early to tell, but we've used it in this mode. We've also used it in the operating room. I was just reading the first patient that we ever used this on was a CMV retinitis patient who had 360-degree, zone 3 and 2 involvement with the typical ratty appearance of atrophic CMV retinitis, total retinal detachment. And so in the operating room, we use that to supplement the retinopathy. And what was nice is, how many of you do retinal surgery? Okay, so you know that it's a very, there's not much give between getting a white hot burn, and it's an exponential relationship to the proximity you reach the retina. With the MicroPulse mode, it allows you a lot more flexibility to come in close and get a large treatment area, and it's not the pop that you hear when you get too close to the surface of the retina. But the guy did quite well. I mean, we did put silicone oil because of the multiple holes, but his retina stayed around, attached very nicely in the periphery.
If you're using 15% duty cycle, are you actually getting a burn?
You are, but it's and again, if you look at least not in the operating room, if you look at what we're delivering, a 500 micron spot size, you know, even on continuous wave, when you fire that, you're not getting a nice, it's the real core is getting white and what have you. This is a little bit more uniform. It's not quite reaching 500, but it's a grayish burn, not even white. I don't see white with that. So it's a grayish burn. Why we started with that for the PDR protocol, the 3-zone, is we knew that we're firing confluency, that there's a potential that you're going to get major pigmentary alteration. We know that you will anyways. So we want to minimize that and see if we still get the same effect of reduction of neovascularization on that. So you do get a grayish visible burn. And then you look 6 months, 8 months later, the pattern is different. It's not a uniform spots on that. You get just a peppering here, peppering there. It's more like a peppered appearance throughout the peripheral fundus.
But that is a scar.
It is a scar, right. One of the things we're looking at too is the overall visual field comparison between conventional proliferative diabetic retinopathy treatment using PRP by the book versus those that are MPLT. And the kind of goal is that if it would be nice to show that with MPLT, even though we're doing all 3 zones confluent, if that, we don't have a microperimeter at our Virginia offices to be able to test. I mean, that would be ideal, but at least to show on visual fields that there is a significant difference. The key being is that as long as you can retard proliferation or neovascularization. Okay, how is it used? And this is the part that I think we like to share. How many of you attended the retina session this morning? Anybody? Oh, yeah, it was in the retina session. The ideal therapy, the ideal treatment, if you will, for macular edema is the greatest reduction in macular thickness in the shortest time with the least amount of side effects and with the greatest duration. Nobody can argue that. That's the. There is no one agent. There is no one agent yet that can give you this. However, pharmacotherapy gets a lot of airplay. Okay, we know that's what we do a lot of. We do a lot of injections, and thank God we have those drugs because they have changed the way we manage retinopathy and particularly macular edema as well. How do we integrate this? And I could share with you how in our clinics we've done this in the last couple of years. Intravitreal anti-VEGF agents are still kind of the preliminary, most common treatment that we offer. They often require more than 3 injections. Steroids are really reserved for marked macular edema and those that have failed to respond to anti-VEGF agents. Obviously, you have to use them with caution in phakic and patients who are either glaucoma suspects or bona fide glaucoma patients. And subthreshold MicroPulse laser treatment can be used in both focal and grid. Typically, we see it 2 to 3 sessions, 90 days apart. That's how we're generally using these. We use it in both combined focal and grid. In the focal mode, it is a photocoagulative, minimally photocoagulative in the continuous wave mode. In grid, it's in MicroPulse exclusively. And high density grid is applied, kind of what I showed you in that earlier slide on the AMD patient with a 5% duty cycle, obviously in a non-photocoagulative state. And typically, and this is not because of the global period, but it works out beautifully. I don't think Iridex had this planned when they did, is even without a global period, you don't touch these patients any sooner than 90 days because of the fact that it's a slow, delayed effect. In focal mode, the real reason I use it in focal mode nowadays is to do a test spot. And again, David already indicated to you how he does his test spots. I typically do it in a non-edematous area, approximately 2 disc diameters from the foveal center. I titrate the power upwards by 20 milliwatts increments until I get a barely visible tissue reaction. And then I multiply that wattage by 4 now. Now again, remember this has evolved. Quite honestly, most of the time I don't do a test spot because I've done this enough times that I will start with a, typically 400 milliwatts on a 5% duty cycle and go. Other users like Victor Chung, who has the 577 as well, they'll go even to higher power ranges, 700, 800, 1,000 milliwatts. I use a Mansour focal grid. The duration is around 200 milliseconds. Power is about 400, 600 milliwatts a noise. Again, maintaining a 5% duty cycle. The technique is a confluent grid pattern, guided really by OCT. And how I approach my macular edema is I divide into 3 categories based on the central subfield mean thickness on OCT. That's the simple way that I approach it. Mild, moderate, and severe. For mild, now my primary treatment is MicroPulse. So it's not drugs. I go straight to that. And again, I used to use it both focal and grid, but again, 99% of the time it's a grid pattern applied even over the microaneurysm, with selective use of anti-VEGF following MicroPulse. In moderate macular edema, I typically start with 2 anti-VEGF injections a month apart. If there's no significant reduction in the macular edema, then I proceed to MPLT. And I've had this question, what do you mean by significant? And in our clinic, in our clinics, we've used 20% reduction. Now, it may be arbitrary, but there's some good reasoning behind it. If there's been less than 20% reduction in the central subfield mean thickness on OCT between baseline and after the second 30 days after the second anti-VEGF injection, then that is considered a failure in us. If there's a response to the initial anti-VEGF injections, I then continue for a maximum of 3 additional injections before proceeding to laser. In our experience, after 6 total injection, it's a flat curve. Yes?
I'm missing the reason for going on and on and on with the anti-VEGF instead of adding the
MicroPulse. That's a good point. The reason being is, again, if there's a lot of edema, significant amount of edema centrally, you may not get the same bang for the buck using laser in general as you would with trying to reduce it with pharmacotherapy. So if we can get by with reducing with the Avastin, squeeze as much possible fluid out of that retina, so you can get to a state where you can use the MPLT, at least in my experience, it seems to be more effective and more durable that way. So if you start, for example, with a fovea that's 500 microns in thickness and swollen, it's got hard exudates, it's going to take a longer time with MPLT to knock it down. So if you can use pharmacotherapy to knock it down, that seems to get the most durable effect. Yes?
It totally dries out, you forego MPLT?
Yeah. I mean, if that's the case, I have done a couple of cases who have dried out and they bounce back a little bit, because the problem is if they bounce back quickly, and then you start from square one. So I've used MPLT increasingly very short afterwards to preserve what I've gained. And that's one of its strengths. But you've got to do it sooner, because if you wait, as you know, the pharmacotherapy is a very narrow window. It'll spring back, and then you have to start again. And these patients, as your patients, they don't like getting shots in the eye. They'd rather, much rather laser than a shot in the eye. So anyways, if they're severe, I mean, remember severe 400 microns and higher, we typically start with 3 anti-VEGF injections monthly. If there is a response, we'll continue for 3 additional ones. Once you get them below 400 microns, again, that's just our experience, you can apply the MPLT. If you can't get it on anti-VEGF, then you use a steroid to knock it down, whether it's triamcinolone or Iridex is a case of vein occlusion. And then even after 1 month, particularly the severe, as we just illustrated, because those severe people, you can pass out the cigars thinking you've cured it, they'll bounce back much faster than those with mild. So we've learned that as soon as you get it flat, do the MPLT treatment and try to get it in then. This is just a summary of the algorithm, and it's available, I think, on one of the handouts. Here's one of the last slides I want to show you. Is interesting, and we were discussing. How many of you practice outside the U.S.? Got one, okay. Well, soon we were discussing over the break, the U.S. will be practicing more like what's outside of the U.S., the way things are. Here is a table just to illustrate, if you hone in on not only this column but down here, the mean number of interventions in 1 year, okay, comparing anti-VEGF monotherapy versus MicroPulse laser therapy. The lowest one is with MicroPulse laser therapy, 1.62 interventions in a year compared to something like 10.2 as was outlined in the RESOLVE study. So, that may not be a big factor for us in the U.S. now, but I think not only in down the road, but also in capitated systems, if you're in the VA or in Kaiser or some similar situation, this may be very advantageous. And also, I put this slide in because I get asked every time we talk, okay, well, how does this affect the bottom line? The laser volume, no doubt, has increased compared to what it was prior to June 2011. Also, the laser session time per patient has decreased dramatically. It's amazing that in our clinic now, because I am, I'm not having to worry about looking at a fluorescein angiogram and an OCT on 2 projections and just making sure I'm dodging this and this. It's real literally, as David illustrated, it's almost like the Singer sewing machine pattern where you're applying a vertical and horizontal scan. The time is equivalent now to our injections, pretty close. Yes, there has been a reduction in the total number of injections I have done because of that, and I'm not worried about that, even though our practice manager might be. And there is, I think, an overall distinct compensation advantage. So in summary, lasers are not going to go the way of the dinosaurs. Their use will continue, I think, in an even accelerated fashion in the next few years. And that's it. Thank you for your patience. Especially we got overtime.